to a non-anthracycline containing regimen, what is so-called the TCH regimen. And this data has now been presented and updated twice. Three times. This is the data from the second interim analysis where it looked like, you can see here the yellow is the AC taxotere arm without Herceptin, and the aqua is the anthracycline containing, Herceptin containing arm, and the red is the non-anthracycline containing, Herceptin containing arm, and those arms did seem to overlap it with very little statistical difference. In the third interim analysis, both of the arms that contain Herceptin also continue to show benefit over the non-Herceptin containing arm, but there is a little bit of a trend towards more benefit with an anthracycline. So Dennis Lehman, who is the sort of the father of the non-anthracycline containing regimen, very much wanted to prove his point that you didn't need an anthracycline for HER2-positive cancers, but I think there's been kind of a trend backwards towards including anthracyclines in patients with HER2-positive disease.
Well, what do those curves look like with no treatment?
With no treatment,
yeah.
I think there'd be a significant drop-off.
No chemos, just surgery.
I think there'd be a significant drop-off within the first 2 years. You know, within the first 2 years, I think you'd expect that, you know, I mean, I don't know if we have any in modern day data like that, but I would expect most people with HER2-positive disease would have recurrences within the first 2 to 3 years. So I suspect that the numbers would be more like, you know, 50% disease-free survival. So here's the data for overall survival. You can see here that the Herceptin-containing regimens are both performing very well. There was also a trial done in Europe to look at giving Herceptin sequentially after any, pretty much any chemotherapy that could be selected. This trial actually is randomizing patients to chemotherapy alone, 1 year of Herceptin or 2 years of Herceptin. And we have the data for the one versus none. You can see here that patients who got 1 year of trastuzumab had significant improvement in disease-free survival compared to those who didn't get any. We're still waiting for the 2 year versus 1 year data. We don't know which is better, and so that leads to the question, you know, how much Herceptin does one really need? Many people in Europe, where they're more interested in cost consciousness, are saying perhaps 6 months of Herceptin would be enough. Although you can imagine that Genentech, now Roche, is not interested in proving that. So back to our patient for the sake of time. The patient completed her chemotherapy and radiation, and then at the completion of her chemotherapy, her last menstrual period was 9 months ago. Although her serum estradiol is in the postmenopausal range, because it hasn't been 12 months since her last period, and because we know that women who are perimenopausal, their periods might stop, but their ovaries might actually recover, we actually treat this patient as a premenopausal patient, and she was started on tamoxifen with the intention of switching her over to an aromatase inhibitor after 2 years. And she completes 1 year of trastuzumab. And so just to summarize the hormonal data for adjuvant hormonal therapy, and again, you're going to get a very good talk from Pam Munster later in this course. The first trials for adjuvant hormonal therapy were initiated over 30 years ago. The data has been updated several times through the Early Breast Cancer Trialist Group. Premenopausal women, you have a number of options, ovarian ablation and suppression. So the first hormonal therapies that were ever used in breast cancer were actually taking out women's ovaries. Then the standard of care now for premenopausal women is still tamoxifen, and then clinical trials are actually looking at the idea of suppressing a woman's ovaries and then adding an aromatase inhibitor. And then in postmenopausal patient, they can receive either tamoxifen or an aromatase inhibitor, but the preferred drug for most postmenopausal patients is going to be an aromatase inhibitor based on clinical trial data. So in terms of the benefits from tamoxifen, in the Early Breast Cancer Trialist group data, which was updated in 2000, they saw that women who were, this is both premenopausal and postmenopausal, 5 years of tamoxifen reduced risk of recurrence by 47% and mortality by 26%. And obviously the benefit of tamoxifen is restricted to ER-positive cancers. So when I meet with patients who say, oh my gosh, tamoxifen is a horrible drug, I don't want to take that, it causes uterine cancer, if I actually show them, you know, that it's actually been a remarkably effective drug for many, many years. However, there is an increased risk of endometrial cancer. However, the rates of endometrial cancer in women under the age of 60 are really quite low. Less than 1 in 1,000 women will develop endometrial cancer. So if it doubles it, it's not very impressive. There's also an increased risk of deep venous thrombosis and pulmonary embolism. Premature cataract formation is a rare ophthalmologic side effect. So when I talk to patients about tamoxifen, the main thing they're focused on is, oh, I hear it causes cancer, I hear it causes blood clots, but the biggest thing is it causes hot flashes, weight gain, and moodiness. And I say to the patient, you know what, that's really what you need to be worried about. You got to take this medicine and see how you feel, and then we'll discuss whether you can stick with it. You know, don't worry about something that's going to happen to 1 in 10,000 patients, and let's worry about what's going to happen to you. So then our patient started on tamoxifen, but if we have a postmenopausal patient, then the aromatase inhibitors are really the hormonal therapy of choice, at least initially, and that's based on data in a number of settings. So the aromatase inhibitors have been compared to tamoxifen as initial treatment of early stage breast cancer, and compared to tamoxifen, 2 of the aromatase inhibitors, anastrozole and letrozole, improve disease-free survival and distant disease-free survival. Neither have been shown to show a survival benefit over tamoxifen. That's very important. In the setting where patients have started on hormonal therapy, took 2 to 3 years of tamoxifen, then switching to an aromatase inhibitor has been shown to both improve disease-free survival and overall survival and reduce incidence of new cancers. And then for women who've completed 5 years of hormonal therapy in the form of tamoxifen, switching over to letrozole actually has been shown to reduce recurrence and improve overall survival. So and when you look at the last 2, you think, well, why is it that you start people off with tamoxifen, you switch them over to an AI, and those people get a survival benefit? Well, it probably selects out that subset of patients who are very sensitive to hormonal therapy. So if you actually did it, most of the trial designs have been that the women who were randomized, and the data that's followed up are from the point of randomization. So if a patient has already had a recurrence on their first 2 to 3 years or 5 years of tamoxifen, they're excluded from the analysis. But nonetheless, there does appear to be a role for this extended adjuvant hormonal therapy, 5 years of tamoxifen, or perhaps 2 to 3 years of tamoxifen, and then some additional aromatase inhibitor. So 2 years later, our patient has completed her 2 years of tamoxifen. She hasn't had a period for over 2 years. We can measure estradiol. We confirm that she's in menopause. So we switch her over to the aromatase inhibitor exemestane. And the exemestane causes tremendous joint pains and stiffness, really interferes with her quality of life. We recommend NSAIDs and exercise, and she doesn't get any relief, so she stops the aromatase inhibitor. And had she come back in to see me at that point, I would have said, you know, hey, no problem, just go back on your tamoxifen, finish up the 5 years, better be on that than anything. But she chose to not take any more therapy. So then a year later, she has back pain, and she saw her primary care doctor. She was kind of embarrassed about not coming in because she'd stopped her hormonal therapy. So her primary care doctor says, give her some ibuprofen and some physical therapy. And she ends up being diagnosed with metastatic disease after getting some plain films and some other imaging studies. So then she's diagnosed with 2 liver metastases and multiple metastases in the bone and spine. So this is kind of how a patient ends up with metastatic disease. Very few patients show up in our clinic with de novo metastatic disease. It's most often that the patient has either completed their adjuvant hormonal therapy or adjuvant chemotherapy, and then several years later they develop some symptoms. And it's always a challenge as a medical oncologist to decide, you know, when do you work up the back pain, or when do you work up the nausea, and when do you try to reassure the patient? And that's an area of the art of medical oncology. So once a patient has metastatic breast cancer, there's still, for someone who's ER positive, there are these hormonal therapy options. Then we have the chemotherapy options, either alone or in combination with some biological therapies. And then there's a lot of debate about how to sequence these things. So here are just the basic schema or idea about the management of metastatic breast cancer. It really depends a lot on the characteristics of the patient and the tumor, as I said earlier on, that if the patient has a metastasis that's limited to the bone and soft tissue, if they have positive hormone receptors, if their tumor is hormone sensitive and it's been several years since they finished their adjuvant therapy, then it's probably not unreasonable to consider hormonal therapy for these patients if they're hormone receptor positive. However, if you have a patient who has visceral metastasis in the liver, the lungs, the bone, plus soft tissue, maybe even presentation in the brain, or if they have cancer that's estrogen receptor negative, or they've progressed rapidly on hormonal therapy, then these are patients that you probably need to start on chemotherapy right away. And so eventually, almost all the cancers will develop resistance to hormonal therapy, even if they started out hormone receptor positive. And so then you have the choices about how do you choose a chemotherapy regimen. And so here's a list of many of the single agent chemotherapies that we commonly use for metastatic breast cancer in first line, second line. We have third line data on some of these, some we don't have first line. But you can see here that the taxanes and the anthracyclines are really the most active regimens for single agent regimens for metastatic breast cancer. And for the sake of time, I'm just going to mention a few of the chemotherapies that we use in the metastatic setting. Commonly capecitabine or Xeloda is an oral chemotherapy. It's a derivative of 5-FU.